Currently, NCCN guidelines lists 4 agents as appropriate in first-line ALK mutant non-small cell lung cancer. 2 of them are crizotinib and crizotinib, gained their approval based on the trials which compared ALK tyrosine kinase inhibitors to chemotherapy. Other 2, brigatinib and alectinib, were approved based on randomized head-to-head comparison to crizotinib. And both brigatinib and alectinib improved progression-free survival over crizotinib. Both have CNS efficacy. So in my mind, I would prefer to go to either brigatinib or alectinib when I treat my patients with ALK-rearranged metastatic non-small cell lung cancer.
In terms of updates over the past several months that have really informed frontline management of ALK-rearranged non-small cell lung cancer, there's been some great updates to clinical trial data that really show the fantastic activity of next-generation ALK inhibitors in ALK-rearranged non-small cell lung cancer. So, updates to the ALEX trial, which randomized patients to receive alectinib versus crizotinib, progression-free survival was about 3 years. And overall survival in the alectinib arm was not reached compared to 57.4 months with crizotinib as the median. So even with crizotinib, the median overall survival was over 5 years, which is amazing, but not even reached for alectinib. And with a progression-free survival of about 3 years as the median, with all these other ALK inhibitors in development, it's really exciting that we're able to bring some fantastic treatments to these patients to meaningfully improve their lives and clinical outcomes. 5-year overall survival was 62.4% with alectinib compared to 45.5% with crizotinib. So well over half the patients alive after 5 years. I mean, if you look at, from a few years ago, not going back too long ago, the SEER database of 5-year survival for stage 4 non-small cell lung cancer, it was like 5%. Now we're looking at these ALK subsets where the majority, it's over 60%, are alive after 5 years. I mean, we need to do better. We need to work on curing patients, but this is this is fantastic. On top of that, the JALEX trial, which was conducted in Japan, PFS was comparable, 34.1 months median versus 10.2 months with alectinib compared to crizotinib at 10.2 months. Median overall survival not reached versus 43.7 months. This was backed up by the Elysia study, which is predominantly an East Asian population, hazard ratio of 0.37 for progression-free survival. So just amazing benefit from alectinib in terms of PFS and OS compared to crizotinib. The ALTA-1 study, median PFS 24 months with brigatinib versus 11 months for alectinib, hazard ratio of 0.49. Reduced disease progression or death by 51%. So some fantastic updates to really pivotal advances in the treatment of ALK-rearranged non-small cell lung cancer.
The management of ALK translocation positive lung cancers has just exploded the last couple of years. It was really just 10 years ago or so that the disease was identified. The first patient with an ALK translocation was diagnosed. And since that time, we've seen the development of multiple generations of agents. And we have the luxury now to have a number of frontline agents to pick from. And the one that was first developed, crizotinib, of course, has fallen wayside because it really does not have good CNS penetration, which is a major deficiency in the management of this particular patient subset with a very high frequency of brain metastases, up to 40–50% in different series. So each and every drug that we want to use frontline, we want to make sure has good CNS penetration and appropriate control of CNS disease. And very luckily, basically a series of drugs that we have now that includes alectinib, that includes brigatinib, and now lorlatinib and crizotinib are joining the crew as well, do have that defining feature. Each of them seem to surpass crizotinib dramatically, doubling or more than doubling the progression-free survival, and that includes CNS disease control as well. Just last week, we've heard that lorlatinib came out with a positive study, the CROWN study, as compared to crizotinib. Just a few days ago at the World Lung Conference, we've heard very nice positive results with ensartinib. So, the list grows in terms of the number of agents that we can choose from. How do we choose from each and every patient? At the moment, alectinib is in the lead because it was the first drug, that showed very positive results as compared to crizotinib, and it doesn't seem to have any, glaring weakness in a way. It has, great CNS activity, and it has a very good adverse event profile as well, very favorable. But we have to continue to watch the data, and ultimately, maybe we'll see some comparison studies comparing some of these outstanding molecules. Both lorlatinib, brigatinib, and ensartinib seem to have great data as well. But there might be some slight weaknesses. Lorlatinib has a bit more of a problematic side effect profile. Brigatinib tends to be well tolerated, but it does have an early pulmonary toxicity that some physicians are a little bit worried about, but most patients are able to get through fine. And ensartinib seems to have a pretty good favorable adverse event profile, but it's coming just a little bit too late to the market in a way. So I think alectinib will remain in the lead for the time being, but it's very nice to have a number of different treatment choices, because not each and every patient will tolerate a drug as well as the average, and having alternatives is very nice. And also some of these drugs can be used at the time of resistance. For example, lorlatinib seems to have great efficacy even in patients who have developed resistance to one of the earlier generation ALK inhibitors. As I mentioned, there's definitely some differentiators in terms of adverse event profiles. Alectinib, very favorable, nothing outstanding in terms of major adverse event of a very significant concern for the average patient. Brigatinib, the sore point is that early pulmonary toxicity, but we've learned how to deal with it, with the dose up titration. And with that, it really seems to be a transient issue and not a serious one. Lorlatinib is a little bit more tricky as a drug to be used because it has some longer term management issues with regards to lipid profile changes, high cholesterol, hypertriglyceridemia, which many times needs to be co-managed. And there's also some potential for mood disorders, which many times need to be co-managed. So I think many clinicians view lorlatinib as a great drug in the second line setting, but a little bit challenging for first line use. And ensartinib is a new molecule that I don't have a lot of experience with, but it does seem, based on reported data, that it has a fairly favorable adverse event profile, maybe similar to alectinib without a whole lot of major issues that stand out.